Arizona to the Rocky Mountains, which is where his heart has always been. So I'm going to turn it over to you.
Thank you. I apologize very much for being late. It's just bad planning on my side. Okay, yeah, that's right. So this is actually meant to be very informal. It's meant to be interactive and things, so feel free to interrupt me anytime. I usually start with a few slides, sort of just to prime the pump and to sort of get some issues on the table that some of you may not be aware of, so you may, if you have further questions about them, we can investigate them. Can we go ahead and get the next slide? So the clinic is actually a fairly large operation at the Anschutz Medical Campus at the University of Colorado. And I have to update this about every day. In fact, I'm 2 people short down here in terms of study coordinators. We have about 6,000 patient visits there. We have over 30 clinical trials right now. We have 7 that are being started over the next month or 2 or a few months. And there's a fairly large laboratory program. So in fact, in Colorado, there's actually a lot of work going on related to MS, particularly on the clinical side, on the side of developing new therapeutics, new diagnostics. Okay, the next one. So I'd like to just cover a couple of basic concepts that are a little bit different, that are not usually talked about in the textbooks about multiple sclerosis, but have a huge impact on our thinking about therapy. And I would say that these are controversial. I'm not sure all of my colleagues would agree with my interpretation of the data, but that's not really important. So, but nevertheless, there's a lot of data related to things I'm going to tell you about. And also, the therapeutic goals that we have now are different than they were a year ago, and very different than they were 5 years ago. And that has also implications for future treatment plans for most patients with MS. Okay, the next slide. So the first thing I just wanted to make sure everybody understands is that multiple sclerosis is an inflammatory disease. There is some debate about that in very extreme circles, but the fact is that the only therapies so far that have modified the disease course have been therapies that somehow impacted the immune system as it interacts with the brain. It doesn't necessarily mean you have to suppress the immune system, but it means you have to change the way the immune system interacts with the brain in order to get some kind of a protective effect to slow down the disease or stop the disease process. In addition, clinicians and patients sometimes view MS as active when patients are having an attack. In fact, that's just the tip of the iceberg. More than 90% of the inflammatory attack on the brain is subclinical. Patients with MS are not aware that there's inflammation going on in the brain, damage to nerve fibers, damage to nerve cells. And then a third point that I would make is that the MS is not a disease of myelin, despite the fact that it's still listed under diseases of myelin in the textbooks. It's a disease of the central nervous system. And we know from a lot of studies now that the actual most important target of the inflammatory attack on the brain is neurons and nerve fibers. And it's the damage to those that determines most of the disability. It's not the damage to myelin. And one of the issues that has not sort of fundamentally trickled down in the medical field is that the implication of that is that remyelinating therapies are not likely to be the answer, the full answer for repair. That in fact, we also have to pay probably even more attention to keeping neurons and nerve fibers healthy. And there actually are strategies being developed that do that. And the next slide. This is a slide that I use a lot in this, but there's many, many papers that address the same issue. And this is actually looking at changes in the volume of nerve cells in the brain in very early disease. So this is in patients who have had 2 relapses, or they met the definition for clinically definite MS, but they still have very short disease durations, an average of 1.9 years. So they've not had MS for very long. The white bar are normal healthy controls, age-matched, and the black bars are MS patients. And what we're measuring is the volume of gray matter in the brain. So gray matter are the nerve cells. That's where the nerve cells reside. So we're separating out the white matter. We're not looking at it at all. We're just looking at the gray matter, which has very, very little myelin in it. And so the changes that we see here are not explainable by damage to the myelin. They're explained by loss of nerve cells. And the point is that patients are losing nerve cells in the very early phase of the disease, even though functionally it has no consequence to them. And that's because there's a fair amount of neurological reserve. We all have neurological reserve, more or less, and that's often partly genetically determined and partly environmentally determined. And as we age, all of us lose nerve cells. It's just part of life. So the brain has sort of this built-in extra supply that allows us to compensate for that and maintain normal function. The problem with MS and other neurological diseases is they are using up that reserve capacity at an accelerated rate, which then can result in early onset of loss of functions. Even if we stop the process, ultimately, just normal aging can result in some accelerated loss of function. So from a therapeutic standpoint, the implication of this is that we're not treating you where you're at today. What we're treating you is where you're going to be at age 65. And the reason that age 65 is important, and we can talk about it more if you'd like, is that by pathological evidence and MRI evidence, in many patients, the disease will burn out around that age in life. I mean, that's a very rough approximation, but in the 6th and 7th decades, MS tends to become less active and in many patients becomes inactive. So if we can shut off the inflammatory attack until you reach that age, then you may move out of the disease phase anyways. And so by protecting brain with these new therapeutics, we can then improve outcomes and allow people to do normal things that they would otherwise do as we get older. Like in my case, I have grandchildren. The next chart. This is a way that we image that cortical reserve. And I realize in here it's kind of hard to see this. Yeah, light switches are tough. This is what's called a functional MRI. And it's just a normal MRI. So if many of you have been in an MRI machine, you know what that's like. This is the same basic procedure. But when the computer analyzes the data coming out of the MRI signal, it throws away the water data and it looks at oxygen levels in the brain and oxygen level in the blood. And so it's able to actually tell us quite accurately how much oxygen is in the tissue and in the circulation in these different areas. And in this particular false color picture, yellow means there's very little oxygen. And so that indicates an area of the brain that's quite active. It's using up the oxygen because it's metabolically active. So when we put people in the machines, we can give them a task to do. We can have them look at a mirror and do calculations or follow a picture. Or in this case, we can have them just tap a rhythm with their dominant hand while they're sitting in the MRI machine. And what you see here in the healthy subjects is that not very much of the brain is activated when you're just tapping your index finger on your dominant hand. But this is an MS patient who had actually clinical isolated syndrome. The patient had just one attack. And what this shows is that even just with one attack, the patient is actually using more of their cortex to do the same thing. They're doing the function normally. They don't notice any problem with their hand, but they're actually consuming more energy and using more cortex to do that. And this expansion of the cortical involvement during the activation process is a process called cortical remodeling. It's where nerve cells that are active and healthy put out new branches called neurites, and they connect with other nerve cells in the vicinity. If you do something while that connection is there, you can make that connection permanent. If you don't do something that captures that pathway, it breaks in about 24 to 48 hours, and the neurite goes somewhere else. So it turns out that professional athletes train the way they do, which is when they're preparing for a meet, they train very intensely, usually on a daily, 6 times a week, as they're trying to maximize their skill sets. And that's because that's the most effective way to capturing this new wiring, which gives them better coordination, better control, et cetera. And the same thing is true for the rest of us. So the reason you can't read about golf and go out and be a good golfer is because you actually have to create new connections in your brain to allow you to do those strange things that are required of golfers. So this cortical reserve capacity masks what's going on in the disease in the first 10, 20, 30 years, depending on the individual. And that's good from a standpoint that patients are functioning pretty well between the relapses, but if our goal is to maximize function over a lifetime, we still need to be able to pay attention to this. And that's why most physicians who manage MS spend more time looking at the MRI than they do at you. Because the MRI gives us a better understanding of what the future may hold for you than just examining on the table, because your body's so good at masking what's going on underneath. Can I have the next slide? So this is a model that I put together that I'm still trying to convince the world is real. And it has some implications. So let me just go over the parts of it. So this is people in young age before the onset of MS. And the onset of MS can be anywhere from age 1 up to age 65. But the average age, if you look at all patients, is around age 29 to 30. And about 85% of people will have onset somewhere between age 18 and age 45, 50, depending on which data you look at. However, the point is that the relapse is the first indication for most patients that they're having a problem with MS. But we know from a lot of studies that by MRI, patients have evidence of disease that's been going on for some time. In some patients for possibly more than a decade. In some cases, maybe even longer than that. And one of the new problems that we have in clinical medicine is because people get MRIs for other reasons, such as headaches, we sometimes pick them up back here before they ever have had their first attack. And that's called MRI, or isolated MRI MS, or MRI isolated syndrome. And we actually now are so comfortable in terms that we can identify this disease even before it presents clinically, that many of us are treating patients that come in with positive MRIs even before they have symptoms. So the paradigm that exists up until this time in medicine, and which many physicians still follow, is that MS is a clinical diagnosis. You have to have had 2 relapses, and they have to be in different parts of the body involving different parts of the brain. That's one way of thinking about the disease, but that's not the way we think about hypertension or diabetes or other diseases. We think of them as biological problems, and MS is a biological problem too. The reason that we use clinical diagnosis is that most of us are old enough that we actually predate the MRI. And so we learned how to diagnose this in a time when we couldn't get a good picture of the MRI of the brain. We couldn't tell that there were MS plaques in the brain. But in fact now we can, and we can do it quite sensitively. And so many of us, particularly at the university, you will see us no longer using that old nomenclature of possible, probable, definite MS based on clinical attacks. We now will look at the MRI, maybe the CSF, some blood tests, and if we don't find other things to explain what we see on the MRI, we'll assume that's MS and we'll proceed with treatment. Now, the other thing that this points out is that if you look at these bars, which represent relapses, there are more relapses in the early phase of the disease than there are in the later phase of the disease. That's not accidental. That's in fact true. As I mentioned, the disease tends to burn out in the 60s and 70s, but it also is decreasing in the frequency of inflammatory attacks as a function of age. That's why when we do clinical studies or clinical trials in MS that last 2 to 4 years, the placebo group is actually getting better or getting fewer relapses over time just as much or significantly compared to the treatment group. Sometimes they actually exceed the treatment groups, which is unfortunate for us.